بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. أهلا بكم ومرحبا في المؤتمر السابع عشر لجمعية أطباء أطفال صعيد مصر.
Good evening, Assalamu alaikum, everybody, and thank you for inviting me to speak in your exciting conference. I'm very pleased to be with you, albeit rather virtually, but Egypt is very much part of my my heart and emotions, as I'm there frequently for the exams. Thank you, Professor Majeed, for inviting me. You asked me to talk about heart failure in infancy and childhood, mainly focusing, I think, on therapy. It was approach and therapy. So I'm Majeed Jawad, consultant pediatrician to Syrian, honorary consultant in the Royal Prompton. So I'm going to talk about heart failure in pediatrics, presentation and therapy. I have no disclosure to make. The outline of my talks will be, as you will see, the overview and definition, etiology, and types of heart failure, presentation, signs and symptoms, therapy, some cases for you to learn, and conclusion. I believe the audience is mixed. That's first liner, general practitioners, and cardiologists. That's why it has mixed knowledge here. So forgive me, our colleagues, cardiologists, if it is not very high powered for you, but that's just to adapt it to the others as well. So heart failure, heart failure, to be honest, is an important cause of morbidity and mortality in childhood. It occurs mostly in the first 3 months, commonly, and rare, although still present after the age of 1 year, especially now that we have advances in surgery. And managing of heart failure is only the first step. That's very important to know. The definition of it in simple terms, it's the inability of the heart to pump sufficient blood to meet the demands. And the general aims to improve and increase cardiac performance. Okay, so it is palliative, the initial treatment, but of course there are ultimate management as well, including surgical routes. The common conditions presenting with heart failure are, as you see, congenital heart disease like outflow and inflow, but we will come through this later. Large left to right shunts and cardiomyopathies and arrhythmias with the storage disease. Don't forget the storage disease as well, because you have lots of genetic and problems like, other rare syndromes, but remain important. The therapy and topics, I go through the causes in order to adapt the therapy. You need to know the cause, and the resynchronization therapy and ICDs, which are part of therapy, ventricular assist devices, transplantation, and I go through some case histories. So the causes in our infants are the structural heart disease like left to right shunts, which are the most common, of course, which lead to volume overload when PVR falls. That's pulmonary venous resistance for our general practitioners. Like VSDs, large VSDs, AVSDs, large PDAs, truncus arteriosus, aortopulmonary windows, large MAPCAs, that's multiple pulmonary and arterial communications, and pressure overload, like obstruction of the left ventricular outflow, like incoarctation of aorta and aortic stenosis, and an Al-Kappa, rare but very important cause for presentation. of cause of heart failure, acute heart failure in children. In infants, arrhythmias are very important. When you have a young infant come to you with the SVT, for example, or ventricular VT or VF, as in cardiomyopathies or myocarditis for the latter, but not the SVT. The SVT usually are isolated. Non-cardiac causes such as anemia, renal failure, hypothyroidism, which can present with edema and heart failure and high output, and the sepsis. Types is main two types are the volume loading one of the left ventricle. That's one of the commonest examples are the left to right shunt, like large VSDs or VSDs, or pressure loading of the left ventricle, or intrinsic muscle failure, like in cardiomyopathies, okay, and myocarditis, etc. Okay, so what are the signs and symptoms of heart failure? For our cardiologists, they know them, of course, but for the general practitioners and first liner, you need to know, very important, the symptoms. They come to you with difficulty breathing, dyspnea, okay? The baby doesn't translate this only with difficulty of breathing, sweating, especially during feeding, poor feeding. They don't finish feeds, mother, they'll tell you. They vomit. And older, they feel nauseating. Older children. Failure to thrive in children, in younger children, that's faltering weight. Restlessness, they are restless because of the, because of the various symptoms. And the poor weight gain, either large or poor weight gain and edema, okay? The excessive weight gain and edema is a late one, of course, late presentation. But on examination, you have the tachycardia, very, very common, that's cardinal, tachypnea, so that's compensatory, like a child with respiratory problem, except they don't have the main respiratory other increased mechanical problems, such as insuctions or suprasternal notch or for grunting, etc. Respiratory distress can still be, of course, with increased work of breathing and tachypnea. Cool peripheries because of poor perfusion, weak pulses, okay, raised JVP, displaced pulse because of the cardiomegaly, crackles, like as if they have pneumonias or things, but they are fine crackles because of the cardiac failure, hepatomegaly, and pitting edema is rather late, and you don't see it in babies. Investigations, you need the cardinal ECG for tachycardia and for arrhythmias, of course, and low complexes for, the viral myocarditis, chest X-ray, cardiomegaly. There's no heart failure without cardiomegaly. Echocardiogram to look at the etiology as well as the consequences with the poor myocardial function and like the functional mitral valve regurgitation, poor function, etc. You need blood tests, of course, for the BNP, the troponin, because of the myocarditis, because of the ischemia, like in for example, L-kappa. In virology, for example, in myocarditis, usinase and LFTs, etc. All these are required, and including the troponin and etc. Nowadays, especially with the complication with the COVID and the MISC and the PIMS. The general management are normally to keep the child comfortable with oxygen, but remember, limited. If you have left to right shunt, you don't give high oxygen. You keep the saturation slightly on the low side because you make it worse. Correct anemia, acidosis, hypocalcemia, and hypoglycemia, and sedation if the child is restless. But of course, this is limited, because you don't over-sedate. And treat associated respiratory infections in children with, for example, left eye shunts come to you in winters or also with the pneumonias or other thing, which make it worse, exacerbate symptoms. You need the specific medication like inotropes, digoxin, dopamine, etc., diuretics, which are the cardinal, of course, in acute cardiac failure, okay, furosemide and spironolactone. These are the commonest we use. The spironolactone to reserve, as you know, the potassium, okay, and the vasodilators, and the beta blocker, and the commonest we use the carvedilol, and of course you use the ACE inhibitors as well. The diuretics, surgery, resynchronization, ICD we use, ventricular assist device and transplant. All these we use. I'll come to this later. Diuretics, as I said, ACE inhibitors, beta blocker, digoxin, and angiotensin receptors. That's in more details. The diuretics in details, they've been shown to improve, they never been shown to improve the survival in heart failure, but they relieve the symptoms. And the action is just by excreting excessive sodium and water in the kidney, like furosemide, and the spironolactone reserve the potassium, otherwise you'll be hypokalemic. Effects just reduce systemic and pulmonary vascular pressure and the edema, reduce pulmonary edema, reverse physiology adaptation, cardiac failure, and do not alter the history of the congestive cardiac failure. Resistance to loop diuretics like furosemide can be a problem if you have other medications like non-steroidal analgesia. Okay, we try higher doses sometimes or other medication. This is a Frank Starling famous law, the relationship between the cardiac output and the end diastolic pressure. And this shows in congestive cardiac failure the relationship of the two. And the diuretics and inotropes, they'll move the end diastolic pressure, improve it to from P, from the lower, to up to 0, to O. Therefore increasing the cardiac output. That's the aim initially as a conservative management. The circulatory failure needs diuretics. These are loop diuretics, and these are the doses. Thiazide we use less than the others, and the potassium sparing, that's spironolactone. Renin angiotensin beta blockers, such as the they block the renin angiotensin system and adverse effects of cardiac failure. The effects reduce after pressure as per the Frank Starling law, as I explained, and increase cardiac output. Renin angiotensin blockers like ACE inhibitors, like captopril we use, but remember when you use the first dose and check the blood pressure, because it can lead to lower pressure, which need resuscitation sometimes, in some cases. Side effect, cough, bradycardia mediated, and start hospital with blood pressure monitoring. And angiotensin 2 receptors, like losartan and the valsartan, the new ones, but they are some of them are better tolerated than the others. The digoxin, which are the oldest, we still use, it blocks the sodium and potassium ATPase pump in myocardium, and increase intracellular calcium and improve efficiency. Effects increase contractibility, slower heart rate, a neurohormonal effect, increasing vagal tone and decreasing norepinephrine levels. The beta blockers, that we don't know the exact action of it or the mode of action, but in adults it decreased mortality 30% and hospitalization by 40%. That's why we still use it in children as well. Good evidence that beta agonist useful despite being negatively inotropic, which is the other side of the coin, of course. Exact mechanism in heart failure is unknown, but prevent and reverse adverse adrenergically mediated myocardial dysfunction and remodeling. Beta blocker, the best of them, we don't use the one which can cause asthma like propranolol or atenolol, carvedilol are selective, okay? Beta 1 and alpha 1 blocker effects reduce neurohormonal activation and vasodilators, antiarrhythmic and slow heart rate and antioxidant. I'm not going to go through the details. Anticoagulation needed if there's a risk of formation of clots, as you know, the thrombus, okay, and we give warfarin or the low molecule heparin or aspirin, of course, or the clopidogrel, the aspirin sparing. Other vasodilator, we use the nitro vasodilators, nitroprusside, isosorbide, and glycerin nitrate. Other drugs like valsartan, as I said, which are different. Inotropes, dopamine and dopitamine, we use them as to improve the contractibility. As I said, the action of dopamine is dopaminergic receptors on renal. We start with renal dose of 10 microgram and then we increase, and it is a vasoconstrictor at higher dose. The inotrope of the adrenaline, beta and beta B1 and beta 2 agonist and increase CMP. There are other medications that's phosphodiesterase inhibitor and milrinone, which we use a lot in intensive care, as I'm sure you know. I'm not going to go through the details of this because these are for more intensive care. Cardiac resynchronization, very important therapy with those with left ventricular dysfunction and dilatation frequently have ventricular conduction delays, like left bundle bunch block, delay depolarization and contraction of left ventricular free wall. So they may end up with the arrhythmias. So you need resynchronization therapy. That's very important. In adult, it shows improved symptoms, exercise tolerance, and quality of life. And echo left ventricular measurements, of course, and the left ventricular measurements will improve the ejection fraction and fraction shortening, and improve survival in adults. We use implantable cardiac defibrillators, for example. Death in pediatric heart failure, it's due to sudden death because of ventricular fibrillation or ventricular tachycardia, or due to pump failure. ECMO is used only bridge for cardiac transplantation, which is the ultimate or the last resort, okay? And cardiac transplantation in UK was the smallest term infant, the smallest child, 40 to 50 per year, with good outcome. The future, we hope, as you know, the myoblast stem cell therapy give us a very good hope for improvement in the end stage heart failure, where all the medications are failed. Okay, there are learning points very important in heart failure. That's drugs. The calories important in addition to the drugs. The drugs, diuretics, ACE inhibitor, digoxin, beta blocker, inotropes. Ventilation important. Beware of oxygen in left-right shunt. Do I need to repeat this? You don't give free oxygen. You make it worse, the heart failure. Mechanical support, transplant, and futures. Now, this will, in a tomb, for example, children who have the mainly need surgery. That's the ultimate, okay? But these medications offer only transient help. So in a 2 months with large VSD, the medical therapy, okay, high calorie, okay, up to 150 mils per kg, captopril start in the hospital, make sure that there's no hypotension, support ventilation if need, inotropes, and oxygen guarded, of course, okay? Fusamide, Prompton, captopril, aspirin, carvedilol, as I said earlier. So the drugs, diuretics, are lots of calories, and beware of oxygen in left to right shunt. Some cases quickly, 3 months old male infant presented to INE with tachypnea, reduced feeding for 2 days, bone term, 3.4 kilogram, no coryzal symptoms, temperature normal, no skin rash, alert on examination but irritable, respiratory rate raised 62 per minute, pulse sinus tachycardia on 76 per minute, blood pressure low 80/50, oxygen saturation 95%, auscultation gallop rhythm, no murmurs, few crackles, both lungs, but rather restless. A liver, there's a hepatomegaly. So it's in failure, no fever, and restless and pale, cardiomegaly. This is the ECG. Very, very important signs. Okay, look at the important signs of the deep Q waves. That's rare but very important because the treatment is surgery. That's Al-Kappa, right? Which is the anomalous left coronary artery from pulmonary artery, okay? And that's very important and can be lethal, okay? So 1 in 300,000 live birth, 0.5% congenital heart disease, and usually isolated, but can be associated with PDA, ABSD, BSD, failures of coarctation. 100% mortality untreated, all surgery, but of course you support initially, okay? I'm not going to go through the physiology. The clinical features, symptoms can be failure to thrive, can be slow sometimes, shortness of breathing, wheezing, angina. They scream, these babies, and they give them antacid or anti-reflux. They think they are refluxing because they vomit. So you have to be careful. Signs congestive heart failure and no heart murmurs. This is, as I said, the deep Q waves, okay? And they can have a ST elevation. So best clue, AVL, deep Q waves, more than 3 millimeter, and T wave inversions, okay? They have mitral valve regurgitation functional as a result of poor myocardial function. Warning, babies with cardiac disease have delayed presentation in cardiology in winter because we attribute this to infections or things in winter. So you have to be careful. You have to have low threshold in diagnosing them. Older children with Al-Kappa, they may present older children with sudden death or collapse or VF or ventricular fibrillation. So any child arrest and requires shock need cardiac opinion, okay? Dilated cardiomyopathy, they present dilated cardiomyopathy, okay? And presentation often insidious and gradual, okay? Treatment strategies, in general, derived from large multicenter randomized. In general, treatment strategies based on the etiology. That's why we say, look at the causes, okay? If you have left to right shunt causing heart failure, you need surgery. Arrhythmias, you need anti-arrhythmia medication, and then ultimately when they are 30 kilogram or above, you need the ablation. Non-cardiac, you treat it accordingly. Treatment strategies are the surgery first. Drugs, they are palliative, all these things that we talked about. If surgery is not an option due to weight of the child, then medical therapy, as we say. Okay, case 2, a 3-month-old boy born 3.6 kilogram, referred to GP, technique, poor feeding, heart, but there's a heart murmur in this, unlike the first case. On examination, alert, restless, and respiratory distress, oxygen saturation 95%, note cyanoid, raised respiratory rate, bilateral crackles and wheezes, as if they are pneumonia or viral infection, temperature normal, pulse high, active precordium with pansystolic murmur with a hepatomegaly, cold extremities, chest X-ray, cardiomegaly, weight lungs with the hepatomegaly, tachycardia, but no deep Q waves like the other one. That's usually left-right shunt. Here we give the diuretics, ACE inhibitors, beta blocker, okay, and then you refer for surgery once stabilization. Diuretics never been shown to improve survival in heart failure. They treat fluid overload, symptoms relief. That's what they offer, and decrease systemic and pulmonary, if you like, and pulmonary vascular pressure. Whereas in a 1-month-old present with tachycardia and no P wave, pale, apprehensive, they might be decompensated in heart failure, or where they need shock, or compensated where they are well, but the cardia, well, they utilize this is SBT, okay? Typical SBT that, you need to treat accordingly, as I say. A rare but important condition, fibroelastosis, disease of infancy, presentation, early presentation with poor prognosis. ECG shows left ventricular hypertrophy with strain. Echocardiography shows dilated left ventricle with poor contraction. Okay, dilated cardiomyopathy. Those who survive first year have good prognosis, managed with medical treatment, but the refractory cases need heart transplant, like any other heart failure failing. It can be either primary or it can be even secondary. You develop fibroelastosis as a result of other conditions later. And that's the severe cardiomegaly and cardiac failure. And, they presented dyspnea, large, heart. As I said, the ECG we've discussed, and that's the myocardial, my normal myocardium replaced by different tissue fibers. Okay. Another rare case, but important, like this, present to us the other day to our hospital, 16 months old, present with peripheral edema, not usual, peripheral edema, breathing difficulty, had a recent upper respiratory tract infection. But when we looked at him, he was short and small for 16-month-old, and he was hypotonic and heart murmur with tachycardia. And this is Barth syndrome, rare Barth syndrome. Syndrome is a rare multisystem disorder characterized by cardiomyopathy, skeletal muscle weakness, and growth delay, and neutropenia. Neutropenia they have. Pathologic variant, that's a chromosomal genetic abnormality. And cardiomyopathy is the most common presenting feature with heart failure. I'm not going to go through details. Another common case, we have a Down syndrome or not a Down syndrome, 9 months old, known to have Down syndrome, presented with repeated lower respiratory tract infection. What are the possibilities here? Is on examination technique, temperature low grade, fever, oxygen saturation borderline low, bilateral fine crackles, tachycardia, and heart pansystolic murmur, best head, left lower sternal edge, hepatomegaly. Chest X-ray shows cardiomegaly, but with mnemonic changes, not just pulmonary edema, probably mixed, okay, but with mnemonic changes. So the manager, you give oxygen, but be careful. What did we say with the left-right shunt? It have to be guarded. Diuretics, intravenous antibiotic, you may need ACE inhibitors, okay? And a repeat chest X-ray later shows improvement of the pneumonia, but of course, still the the cardiomegaly and the sinus tachycardia. Echocardiogram IVSD, okay? And that's the other things. So in summary, pediatric heart failure represents an important cause of morbidity and mortality in childhood. Currently, there are well-established guidelines for the management of heart failure in adults, but the pediatric ones, including the AHA, the American Heart Association, they were rather late, 2017 or so, to be established. With the Canadian one and the British ones, okay? But diuretics, angiotensin converting are the first-line therapies, where beta blocker and devices for electric therapy are less used in children than adults. The end stage is the transplantation. These are the points I covered, and I hope I covered all the important points. Thank you very much, and lovely to be with you. I'll be soon in UK as a senior examiner for the MRCPCH.
عمل دؤوب لا يتوقف من إدارة جمعية أطباء أطفال صعيد مصر، الذين لم يبخلوا بوقتهم وعلمهم وعملهم من أجل الارتقاء بمبادئ وأخلاقيات مهنتهم السامية. سعي مستمر بخطوات ثابتة نحو تقديم العون لتوفير مجتمع آمن ومعاف.